Hello everyone. In this video, there is a male patient, 19 years old, non-traumatic cataract since 10 years, presented to me with vision 0.1, corrected up to 0.8 with minus 11 cylinder with minus 2 cylinder. On examination, this is a traumatic cataract. There is a prefrontal synechiae, posterior synechiae, captured PMMA IOL, open posterior capsule, and the fundus examination revealed no abnormality. And the other eye was completely normal with no error of refraction. So I need to IOL exchange this case. So can I restore the vision of this patient after 10 years? Is it possible? We are going to see in this video. Very important to do your paracentesis opposite to the area we're going to deal with, which is the other side. With a visco-dispersive, which is very important to maintain your anterior chamber IOP, also to protect your cornea, and to smoothly dissect your area without injuring the iris. So I'm injecting the viscodispersive under the iris where the area of posterior synechiae to see where is it. Then with a micro scissor, I am trying to cut the peripheral anterior synechiae. There is two. I already cut it now. Then trying to cut the posterior synechiae and not to touch the iris tissue, which is very important. You're only cutting the synechiae, the fibrous tissue between the iris and the anterior capsule, trying to reform the sulcus for secondary IOL implantation. Now you can see how the iris tissue is starting to enlarge or to spread to see the tissue of the iris. More and more, injecting your visco-dispersive under the iris, trying to see where is the remnant of this synechiae also. Again, with the scissor, you cut more and more. Now I am completely cutting all the synechiae in the sulcus. In this time, I open the wound. This is a PMMA. I cannot cut it, so I want to remove it. I prefer the peripheral corneal wound more than the sulcus to deliver this, because this is the steep part of the cornea before the operation. So opening the wound, it's going to decrease the astigmatism, enlarging the wound from inside to outside, this making the edge of the wound neat for suturing. Injecting more visco-dispersive to protect the cornea and under the PMMA IOL to protect the anterior vitreous, and trying to dislodge this PMMA hard lens in the anterior chamber with minimal rotation. So with the MacPherson, I captured the first haptic, rotated more. It was highly adherent. When I got it removed, it was broken. So I catch it from the optic and bring it slowly. This area is attached to the uveal tissue. Slowly, then remove it. This is the IOL with the broken haptic. It's also a very weird IOL. This is not the usual IOL I usually seen. It's a little bit oval, not rounded. So it is not 6 mm, it is 5 mm. And this is the remnant of the broken haptic of the PMMA. You must be sure that you remove all the IOL. You cannot trim it from the. This is a very hard lens. Proper anterior vitrectomy is done with parameters. It's an open sky, so take care you do it fastly, properly. And now you see the iris tissue becoming, the pupil becoming rounded now, because you remove all the adherent vitreous. You remove all the IOL which was captured in the edge of the pupil. and the pupil is starting to become rounded. At this time, I injected visco-cohesive in the sulcus to reform the sulcus, and I prefer to put a sensor 3-piece because this is a joker lens, because if I failed to put it in the sulcus, I can do a mani technique for this case. And also I believe that the haptics of this lens is so soothing in these cases, because this is not the normal sulcus you have. So PMMA lens in these cases, it will be more hard, and it can lead to more iris trauma in the future, and also it can lead to more captured again for the PMMA. So I used this 3-piece lens, put it in the sulcus, injecting more visco-dispersive, then rotation of the lens in the sulcus, and centraling the optic, soothing the iris, and the iris is nearly rounded. I close the wound with 4 sutures, 10-0 stitches, injecting subtenon steroid to decrease inflammation post-operatively, and also I injected air in the anterior chamber to maintain the IOP. After I finish the case, post-operatively, the first day the vision reaches 0.6 with -3 cylinder because of the stitches, and after 1 month I remove the stitches and I reaches 0.5 cylinder and the vision 0.8. Thank you for watching.